I'm one of the PGY 5 cardiology residents here in Toronto, and I'll be reviewing these 2025 guidelines. And these replace the 2010 guidelines, so it's a big update over 15 years of new data. And rather than going page by page, I've distilled it down to what I think are the most important parts and what may actually change how we acquire, interpret, and report the right heart on echo. So here are some of my objectives. One, we're going to review updated normative values and severity grading for right heart chamber size and functional parameters from the guidelines. Two, we're going to integrate multiple echo measures of RV function to avoid pitfalls of relying on a single parameter in isolation. Three, we're going to utilize non-invasive hemodynamic assessments of RV-PA coupling ratios to screen for pulmonary hypertension. And four, we're going to recognize echo features of adaptive versus maladaptive right heart modeling, specifically in pulmonary hypertension. Here's a brief outline of our talk for today. And so the right ventricle historically has been defined as the forgotten ventricle. And that's because a lot of our clinical decision making is very LV centric, but it's important to note that RV failure is actually the leading cause of death in pulmonary hypertension. But not only that, RV dysfunction independently predicts mortality in heart failure, acute PE, post-MI, post-cardiac surgery, and even ARDS. But kind of despite this, a systematic approach to RV assessment and echo remained quite inconsistent. And that was until the 2010 ASE guidelines, which were a huge step forward in drawing attention to the right heart. And now in 2025, after 15 years, we've accumulated a lot more data, updated normative values from large epi cohort studies, and integrated new techniques like strain and 3D echo, um, all of which have been included in the 2025 guidelines. So before we get into the numbers and the crux of this presentation, let's remind ourselves of why the RV is so hard to assess on echo. So unlike the LV, which is a nice symmetric sort of bullet-shaped structure, the RV is complex in that it's crescent-shaped and it wraps around the LV, as shown in this diagram. It wraps around the LV, and it has three distinct components to it. One is the inlet, which contains the tricuspid apparatus itself. Two is the trabecular apex. And three is the infundibulum, or the outflow tract itself. So unlike the LV, the RV's complex shape can't really be measured from a single geometric model like Simpson's biplane. And that's why multiple views are required, and that's why the RV-focused apical four-chamber view is so critical in our assessment of the RV. There's also no clear anatomical landmarks to standardize our views like the LV, right? Small changes in your transducer angulation produce like dramatically different measurements. And finally, the RV free wall itself is quite thin. It's only about 3 to 5 millimeters, and it's heavily trabeculated, which makes the kind of demarcating the endocardial border that much more difficult. So how do we overcome these challenges in some ways? So the answer is in part the RV focus apical four-chamber view. The standard four-chamber apical view is optimized for the LV here. The LV apex is kind of centered here on the screen, and the RV is off to the side and is foreshortened a bit. The RV focused view is obtained by starting from the standard four-chamber view, and then you rotate your transducer slightly counterclockwise while keeping it at the apex, and you're making fine adjustments to maximize that RV cavity area seen here on the screen. And critically here, the LV apex will no longer be centered, and that's okay. This is not an LV view anymore. So before we go into the echo-specific pulmonary hypertension concept, let's ground ourselves in the hemodynamic definitions, because everything we're really doing on echo is trying to non-invasively approximate what the right heart cath would tell us. So hemodynamically, pH is defined as a mean arterial pressure greater than 20 millimeters of mercury, and this was lowered from 25 millimeters of mercury in 2022. And along with that, the pulmonary vascular resistance threshold was lowered from 3 to 2 Woods units. And then hemodynamically, you can further divide them into precapillary pulmonary hypertension, defined as a wedge pressure of 15 or less, and an elevated PVR greater than 2 Woods units. Isolated postcapillary pulmonary hypertension, which is defined as a wedge pressure greater than 15 with normal Woods units of 2 or less. And finally, combined pre and post capillary pulmonary hypertension, where your wedge is elevated and your PVR is elevated beyond 2 Woods units. And finally, the guidelines go over exercise pulmonary hypertension, which is defined as a ratio of your mean pulmonary arterial pressure over your cardiac output slope of greater than 3 millimeters of mercury per liter per minute. And clinically, the World Health Organization further divides pulmonary hypertension into 5 different groups. So, group 1 pulmonary hypertension or pulmonary arterial hypertension. Group 2 is pulmonary hypertension due to left-sided heart disease, so patients with HFrEF, HFpEF, valvular disease. And this is by far the most common form of pulmonary hypertension. Group 3 pulmonary hypertension or PH associated with lung disease, so patients with COPD or kind of chronic untreated OSA, for example. Group 4 pulmonary hypertension, which is PH associated with pulmonary artery obstruction, so think of chronic thromboembolism pulmonary hypertension. And group 5, which is basically multifactorial or unknown mechanisms of PH. So pH is fundamentally a disease of increased RV afterload. Okay, because the RV is thin-walled and normally ejects into a low resistance circulature in the lungs, it's very sensitive to increases in pulmonary vascular resistance and pressure. So in chronic pulmonary hypertension, the RV initially adapts through hypertrophy and increased contractility. And by doing so, you maintain what we call the right ventricle pulmonary artery coupling and forward flow. That concept of RV-PA coupling basically means that the longitudinal strain of the RV, it is matching the afterload that is required to maintain that cardiac output. But as time progresses, the RV starts to fail. And by doing so, you have progression in RV dilatation, worsening tricuspid regurgitation, rise in your right atrial pressure, and you ultimately get into points towards end-stage pulmonary hypertension where you have uncoupling of your RV and your PA. The RV is no longer able to overcome that afterload. And this is a nice diagram here on the right that basically walks you through your hemodynamics values as a function of time. So in the asymptomatic stage, your right ventricular hypertrophy is increasing while your mean PAP is increasing as well to meet that demand. And finally, when you get into that symptomatic decompensated state is where you're no longer able to hypertrophy the right heart anymore. Your end diastolic pressure starts increasing, and ultimately your cardiac output starts to decrease, and the patient is now in real trouble. And so this is a sneak peek into kind of echo features of progressive pulmonary hypertension. And we'll come back to a lot of these things like chamber dimensions and eccentricity index. But for now, I just want you guys to appreciate the visual progression. And so at the beginning, you may begin with mild increase in the wall thickness and some increased cardiac output, but the patient may be asymptomatic at this stage. As you progress in pulmonary hypertension, you develop maladaptive remodeling where the RV can no longer keep up. The chamber starts dilating, the contour starts shifting, and you start to see something called apical traction here. And that's where the apex is being tethered leftwards towards the LV, signifying that the RV is weak and it can't counteract LV forces. And then finally, you reach end stage here where you have significant RV dilatation with bowing of the interatrial septum into the LV. You can have significant tricuspid regurgitation. Your eccentricity index will start to become abnormal, and we'll start going through all of these later. So let's get into some details from the guidelines on the qualitative and quantitative assessment of the right heart, and we'll begin with the right atrium. So this is historically kind of the least studied chamber, but it does have real prognostic weight. There was a meta-analysis that showed that every 1 centimeter square increase in the RV area equals about a 6% increase in the risk of mortality and morbidity in pulmonary hypertension. Um, and so RA volume is traced, an area are traced at end systole. So you can use either the method of discs shown up here or area volume here. And the guideline recommends including the RA area or index in your standard reporting, which is a change from previous practice. In normal, they define an area of less than 19, an index by method of disc is less than 30, which is sex independent, and by area length of less than 32. But for daily practice here in the right ventricle, the RV basal dimension, as shown here, is kind of the single most important linear measurement that we use. And the guidelines define a basal diameter of less than 4.1 as a centimeter as normal, or less than 2.4 centimeter per meter squared when indexed. But they also, of course, recommend measuring the midsection as well, so less than 3.5 centimeters is normal, and a longitudinal section parallel to your septum, defined as normal as less than 8.2 centimeters. The RV wall thickness should be less than 0.5 centimeters, measured from the subcostal view at end diastole. And for uh, in regards to area, they recommend getting your end diastolic area and your end systolic area with normal defined as less than 25 and less than 14 centimeters squared, respectively. And finally, something that's new is they recommend getting 3D volumes as well, defined as an end diastolic volume of less than 130 milliliters or an end systolic volume less than 66. Something that should be noted is that in pulmonary hypertension, in the maladaptive remodeling, you actually get the mid-ventricular dimension increasing before the basal dimension. So if you're only measuring the base here, you may miss early dilatation. So moving on to the interventricular septum, and the septum is really a real-time pressure gauge between the two ventricles, and you're quantifying its position, which will tell you whether the RV is dealing with volume overload, pressure overload, or a combination of the two. And the marker that we look for is something called the left ventricle eccentricity index, or LVEI. And that quantifies the septal flattening from the parasternal short axis. The equation itself is quite simple. You're basically looking at D2 here, which is anterior posterior, to the ratio of D1, which is septal to lateral. And a ratio of 1 is normal, right? Your LV is spherical throughout cardiac cycle. A ratio greater than 1 in end diastole is signifying RV volume overload, whereas in end systole, it's signifying combined pressure and volume overload. This isn't a bulletproof kind of measurement. It is unreliable in some regards, in that it's unreliable if you have a left bundle, if you have pre-excitation, paced rhythm, and it's not validated in post-cardiac surgery patients or in constrictive pericarditis. Finally, the guidelines include assessment of the main pulmonary artery. So the main pulmonary artery dilates in response to both volume and pressure, just like the right heart chamber. And the 2025 guideline defines an MPA end diastolic diameter greater than 25 millimeters as abnormal. And that's measured from the parasternal short view, just distal here to the pulmonic valve, which would be kind of up here. Um, An important adjunct to the MPA is to get the ratio of the MPA to the ascending aorta. And that's because a ratio of one or greater is abnormal, and it's been shown to be a strong predictor of both the presence and the severity of PH because it correlates quite well with your PVR and your mean pulmonary arterial pressure. And something to keep in mind is that in your 2D echo values, when you get your MPA, they're usually smaller than what you will find on your CT or CMR. And that has to do with kind of where you're measuring it in the cardiac cycle. But don't be surprised if that's the case. That's to be expected. It's not a discrepancy. Okay, so now let's move to the functional assessment of the right heart, and we'll begin by the parameter that a lot of people are familiar with, and that's the tricuspid annular plane systolic excursion, or TAPSE. And this is really the workhorse of your RV functional assessment. You basically place the M mode cursor through the lateral tricuspid annulus, as shown here from the RV focused view, and you're basically measuring how far the annulus is moving towards the apex during systole. And so what it does is that it captures longitudinal shortening of that basal free wall segment only. It doesn't tell you anything about the other segments. Um, so think of it as just sampling one point on a very complex ventricle. And so when that point is representative of the whole chamber, TAPSE is great. But when it's not, it can mislead you. So the guidelines, keep the normal threshold as before, of greater than 1.7 centimeter as normal, but they provide a severity grading here as shown. And TAPSE may be underestimated in cases classically described in the literature in post-cardiac surgery patients. So after any sort of CT surgery, whether that's CABG or valve surgery or pericardiectomy, your TAPSE will drop, and sometimes it'll stay low permanently. But that doesn't necessarily translate to the RV is failing. Studies show that after surgery, the RV shifts in this contraction pattern and without having clinical significance for the patient. And so when CANTAPSE overestimates RV function, and that this is probably the most dangerous pitfall, and it's actually in advanced pulmonary hypertension with maladaptive remodeling because the apex, you get that apical traction, it's tethered towards towards the LV, and the basal segment will start looking hypercontractile. But really the RV is failing. And so the guidelines recommend overcoming this by pairing your TAPSE to your pulmonary arterial systolic pressure or your right ventricular systolic pressure. And this becomes a non-invasive surrogate of your RV-PA coupling. It tells you whether that RV is able to match its afterload. And so in a healthy individual, that ratio is typically around zero point 0.5 to zero point 0.7. If you look in the literature, there's quite a bit of range that various uh, guidelines give, but the ASC 2025 guidelines gives zero point 0.5 to zero point 0.7. And in pH, a ratio of zero point 0.3 to zero point 0.4 millimeters per millimeters of mercury is associated with uncoupling and increased mortality. And so this was a nice study by Bobot and colleagues from Jack in 2024. And in this graph in A, you have survival basically as a function of time in patients with pulmonary hypertension. And they looked at TAPSE to your PASP ratio. And what you see here is that in the lowest quartile here, defined as a TAPSE to PASP ratio of less than 0.42, they had an adjusted hazard ratio of 1.68 compared to this highest quartile here in red. And you can clearly see like a clear separation in the survival curves by 12 months, and that certainly extends all the way to 60 months. So tissue Doppler imaging S prime. So this is kind of like your sibling of TAPSE, and what you're doing is that you're measuring the same thing at the same location, but just in different units. So TAPSE measures how far the annulus moves in millimeters, and your S prime is measuring how fast it moves in centimeters per second. And so what you're doing is that you have your pulse wave Doppler sample here, at the lateral tricuspid annulus, and you're optimizing the baseline so that the S prime wave is clearly above and the diastolic E prime and A prime waves are below. And so the guidelines set the normal threshold at greater than 9.5 centimeters squared with a severity grading scale provided here. And again, just like TAPSE, it kind of shares the same fundamental limitations in that it's a single point measurement of longitudinal function. So it doesn't tell me anything about the right ventricular outflow tract or the septum. And therefore, it can be underestimated in things like cardiothoracic surgery patients. So now we'll move on to fractional area change, and this is where we start getting a more global picture of RV function. And unlike TAPSE and S prime, your FAC captures both longitudinal and radial contraction by tracing the kind of entire border of the RV endocardium, both in diastole and systole. And when you're tracing it, you're basically tracing everything. You're getting the pap muscles, the trabeculations, the moderator band, as well as the entire cavity area. The formula itself is pretty straightforward. It's just the difference in your RV end diastolic and systolic areas over your RV end diastolic area multiplied by 100. And uh, according to the guidelines, again, the normal is greater than 35%. But now in these guidelines, they also again provide a severity grading as outlined here. And the key advantage over TAPSE and S prime is that it correlates better on your MRI than either of these functions. So if you're in a case where your TAPSE and your S prime are discordant and you don't know what's really happening, consider getting your fractional area change. Um, and so something new in the guidelines is something called right ventricular strain. And unlike TAPSE and S prime, your right ventricular strain is a more sensitive and early marker of right ventricular dysfunction. So key numbers in terms of your right ventricular free wall longitudinal strain, where you look at three segments, the basal segment, mid, and apical free wall. Normal is considered greater than 20%, whereas severe is less than 11%. In terms of your right ventricular global longitudinal strain, which looks at six segments, that's also defined as another parameter to be used in the guidelines when measuring this. And you really get it from your RV focused view in your apical four-chamber at 60 to 90 hertz frame rates. And why does this matter? Why did this make it into the guideline? It's really for multiple reasons, but it basically captures what TAPSE and S prime miss. So in there was a sub-analysis of the patients in the Paragon heart failure trial, and they found that over half of these patients with HFpEF had normal TAPSE and fractional area change, but they had impaired RV strain. And so RV strain is prognostically superior to both TAPSE and your fractional area change. So next we'll move on to your RV diastolic function. And this becomes abnormal often before your systolic function does. And so it has three components to it, and you're already set up for two of them when you're at the tricuspid annulus, right? So your first is your tricuspid inflow Doppler, where you're placing that PW sample at the tips of the tricuspid leaflet from the apical forechamber. And that gives you your E wave, which is your early passive filling, your A wave, which is your atrial contraction, and then you look at your ratio. So a ratio E to A that is normal is 0.8 to 2. And you also look at your deceleration time, which is defined as normal as 120 to 230 milliseconds. And the critical point to this is that you have to measure this at end expiration or an average of over 5 beats. And that's because your tricuspid inflow velocities are very sensitive to respiration, much more so, than your mitral inflows. Just be cautious of that. You also look at your tissue Doppler, where you're looking at little e prime, a prime, as well as your E to E prime. And that's looking at kind of your passive filling to your myocardial relaxation. And that's kind of measuring your TDS, your TDI-S prime that we talked about. And finally, you're looking at your hepatic vein flow. So normally you see systolic predominance where the S wave is taller than the D wave. And so a normal ratio is greater than 1. And so if you have a case where that's flipped, so it's less than 1, that's diastolic predominance, and that's a sign of early RA pressure overload. So just be cautious of that. And so the guidelines here also give severity grading for this. I won't go over this in detail, but just for your reference. And so far, every parameter that we've discussed has measured the RV in isolation, but the RVOT Doppler signal is unique because it's the one measurement that actually gives you insight into what's happening into the pulmonary vasculature itself. And so the RVOT VTI, it's obtained from the parasternal short axis at the aortic level. And you have your pulse wave Doppler sample just proximal to the pulmonic valve, okay? And so the acceleration time is measured from the onset here to its peak velocity. And in a normal compliant pulmonary vascular bed, the envelope is parabolic, and I'll show you an example in the next slide. So normal RVOT VTI is greater than 18 centimeters. And when you combine it with the RVOT diameter, it gives you your RV stroke volume and output. But the shape of the envelope is important as well, because it's a reflection of the pressure waves from the pulmonary vascular resistance. So if we look at this diagram here, so on the far left side, this is a normal Doppler. So it's smooth, it's symmetric, it's dome peaking in mid-systole. And so this means that there's low resistance and high compliance. In early pulmonary hypertension here in B, the peak is kind of shifting forward and the shape becomes more triangular. And so the acceleration time is starting to shorten. As you progress in pulmonary hypertension and you get into this moderate severe range, you have something called mid-systolic notching. This is reflecting increased pressure waves from a stiff pulmonary vasculature. When you're seeing this, you're establishing pulmonary vascular disease. You're not just establishing elevated pressure. And finally, when you get into this advanced pH stage where you're having RV-PA uncoupling, that's when you start having rapid deceleration, and it's a really ominous sign that the patient is in trouble again. And so let's wrap up the technical aspect of this discussion by quickly discussing hemodynamics and reminding ourselves of a few things. So your pulmonary arterial systolic pressure, or your RVSP, is 4 multiplied your peak TR velocity squared plus your right atrial pressure. Your pulmonary arterial end diastolic pressure is 4 multiplied your end diastolic PR velocity squared plus your right atrial pressure. And the guidelines give you multiple validated ways to measure your mean pulmonary arterial pressure as outlined here. And your PVR, or your pulmonary vascular resistance, is your TR velocity over your RVOT VTI multiplied by 10 plus 0.116. One quick comment about measuring your TR velocity is that, remember, you really want to measure what they call the chin and not all of this fluffy, hazy artifact beyond that. Otherwise, you'll be over measuring your TR velocity on your CW Doppler. So how do we put this all together in practice? So the guidelines give us a clear screening checklist. So if you have a patient with a resting TR velocity of 2.9 meters per second or greater, that is suggestive of pulmonary hypertension. But the major update is that if you have a TR velocity of 2.8, with at least 2 adjunctive signs, that should also raise suspicion for pH. And these adjunctive signs, we talked about these. So these include an RV basal diameter greater than your LV diameter, an LVEI of greater than 1.1, mid-systolic notching on your RVOT signal, an end diastolic pulmonary regurgitation velocity of greater than 2.2 meters per second, a dilated IVC greater than 2.1 centimeters, an RA area of greater than 18 centimeters squared, and a dilated pulmonary artery greater than 25 millimeters. And so this is from the guidelines directly as a algorithm that can be used. So if you have a patient with TR velocity of at least 2.9 meters per second, you basically are looking at if they have they're basically concerning for pulmonary hypertension, and so you should look at kind of your cardiac output here and suspect pulmonary hypertension. But if you don't meet that criteria, but you have a TR velocity of at least 2.8 with some of these adjuvant signs, that's also suspect for pulmonary hypertension. But what if you have a case where the TR jet is less than 2.8, but that's because you might have an insufficient TR signal? Again, the guidelines say if you have some clinical suspicion, look for these criteria. And if these criteria are there, then suspect pulmonary hypertension. And so that's a useful algorithm included in the guidelines. And so I want to go over a case study quickly, and this is a real patient that was scanned a number of years ago. And so he was a 64-year-old gentleman with idiopathic pulmonary arterial hypertension on tadalafil and ambrisentan. So tadalafil is a PDE5 inhibitor, and ambrisentan is an endothelin receptor antagonist. And you get this TTE requisition, and the indication is just worsening dyspnea. So I'll go here. So I'll just let this video play for a little while. So this is your parasternal short axis view at the level of the aorta here. So you have your right side here with your tricuspid valve up here, your PA here, and your RVOT kind of up here. And so this is your parasternal shorts from the level of the papillary muscles. And you can see if, and we'll go over all the numbers after, but you can see how this septum is D-shaped. You can appreciate how this ventricle here is D-shaped. So this is measuring TAPSE here with M mode along the tricuspid annulus. And it is abnormal. And again, we'll go over the numbers. And so here, sorry about that. Let me play it again. So here you have your RV focused apical four chamber view here on the left with your color Doppler here on the right. So a few things here. Notice how dilated the RA is, and notice how the interatrial septum is bowing very significantly into this LA. You can see how dilated the RV is itself, both the basal diameter as well as the mid diameter. And it's cut off a little bit here, but this patient did also have apical traction where this RV apex is very leftward towards the LV. You can see here on the right, he has significant severe tricuspid regurgitation. And so this was his TR velocity, and he came out to about 5 meters per second. This is his IVC here. So very dilated, not collapsing. And these were his values. So these are ASE 2025 guideline severity markers here, and these are our patient values here. So he had right atrial volume index 48 in the severe range, basal diameter of 4.9 centimeters, which was actually in the moderate range for him. The TAPSE was 1, so that was severe. His TDIS prime was 5.3 in the moderate range, but his TRV max was 5, which was severe. And from there, we can calculate the RVSP, and his came out to 115 millimeters of mercury, so very high. And his mean pulmonary artery diameter was 2.6 in the mild range. His left ventricular eccentricity index was 2, so very abnormal. And this was abnormal, as you saw, both in diastole and systole, so it was a marker of pressure volume overload. And then I calculated his TAPSE to pulmonary artery systolic pressure, and it was extremely low. Remember the diagram that showed that patients with less than 0.42 had a 12-month survival of about 60%, and his is less than zero point 0.1, so he was very uncoupled. And so afterwards, he got a right heart cath as well, and you can kind of expect what you would see from this. And I forgot to mention this, but his left heart was completely fine. So he had a mean pulmonary artery pressure of 48, so extremely high. So pulmonary hypertension is established. His wedge pressure was 5, so his LV was okay. And his PVR was extremely high at almost 14 Woods units, with a cardiac output of about 3.17 liters per minute by Fick, but when indexed, it was low at 1.78, and he had a negative vasoreactivity study. And so this was a case of pre-capillary pulmonary arterial hypertension that was confirmed with a right heart cath as well. And so to start wrapping things up, I just want to touch upon the echo features of pre and post capillary pulmonary hypertension. And this can really be a lecture in itself, but it's important that we have an idea of how echo can be used to help phenotype pH. So here on the left-hand side where you have pre-capillary hypertension, notice the massively dilated RV, the RA as well, and notice how large these are compared to your left-sided measurements. Uh, um, uh, and so you have this small underfilled LV and LA. You would have this D-shaped septum in the short axis, dilated IVC as well. And then in your post-capillary kind of measurements here on the right side, you would have those kind of things, but also markers of LV dysfunction. So whether that's LV hypertrophy up here, a normal kind of LV eccentricity index, a dilated left atrium. You might have grade 2 or above diastolic dysfunction and an abnormal peak TR velocity of greater than 2.9. So although echo is not suited yet to replace the right heart cath, it does give the clinician an idea of whether they're dealing with pre or post capillary pulmonary hypertension. And so, just some of the take-home points that I want to emphasize from this talk is that never rely on a single parameter, right? So remember, your TAPSE can overestimate the function with apical traction. Your S prime can overestimate with leftward tethering. Your FAC misses your RVOT. Your strain is load dependent. Each metric has a blind spot, and the power of echo, as emphasized on the guidelines, is an integrated assessment. If one parameter says it's normal, but the RV looks sick, trust your eyes and get more data. Use the RV focused apical four-chamber view for assessment. Remember that the 2025 ASE guidelines now provide severity grading as well, and these should be incorporated into our echo reports. Screen for pulmonary hypertension using your TR velocity as the gatekeeper. Not your estimated RVSP. Okay. Remember that your TAPSE to your PASP ratio is a powerful prognostic ratio, and a signal that you might have RV PA uncoupling if low. And in terms of phenotyping pulmonary hypertension, use your left heart to try to distinguish if it's pre versus post capillary hypertension. But just remember that this is non-invasive and it doesn't replace the right heart cath itself. And so that's my presentation. I hope everyone enjoyed and happy to take any questions.